organophosphate and carbamate poisoning. This is one of those conditions where rapid recognition can literally save a patient's life. Over the next few slides, we'll move step by step, from mechanism to clinical signs to airway management, antidotes, complications, and finally the practical emergency protocol. Think of this more like learning a clinical story. Now let's focus on the central mechanism. On the left side of this slide, you can see a synaptic cleft with built-up acetylcholine. Normally, acetylcholinesterase rapidly breaks down acetylcholine at synapses, but organophosphates and carbamates inhibit that enzyme. So what happens? Massive accumulation of acetylcholine at the synaptic cleft, causing unrelenting depolarization. And that explains why these patients look dramatically cholinergic. The red X across the enzyme symbolizes failure of acetylcholine breakdown. Symptoms due to muscarinic overstimulation and nicotinic overstimulation are listed in the flowchart. The central nervous system involvement leads to agitation, seizures, coma, and respiratory depression. Keep in mind our exam pearl on aging. We shall discuss it in the next slide. One of the most important clinical concepts here is this. Patients often die from respiratory failure, and the cause is usually multifactorial. Excessive secretions, bronchospasm, central depression, and muscle paralysis all occurring together. So throughout this lecture, keep airway and breathing in the back of your mind. Now let's compare organophosphates and carbamates. This distinction is extremely important clinically and also very commonly tested. On the left side, you see organophosphates. These agents phosphorylate the enzyme. That bond becomes very stable and irreversible over time, a process called aging. Once the enzyme has aged, it cannot be reactivated. That's why early oxime therapy matters. Now compare that to carbamates on the right side. Carbamates carbamylate the enzyme, but the bond is usually reversible and short-lasting. In many carbamate poisonings, the enzyme spontaneously recovers. That's why oxime therapy may be less useful and in some cases potentially harmful. Another key distinction is CNS penetration. Organophosphates are often highly lipid-soluble and penetrate the brain effectively. That's why CNS symptoms can be severe. As you study toxicology, try not to memorize isolated facts. Instead, connect the mechanism to clinical behavior. Stable, irreversible inhibition leads to prolonged toxicity. Reversible inhibition leads to a shorter disease duration. That framework makes everything easier to remember. This is the cholinergic toxidrome. If you can recognize this pattern clinically, you can diagnose organophosphate poisoning rapidly, even before laboratory confirmation. Let's start with the muscarinic effects on the left. The classic mnemonic here is SLUDGE. Salivation, lacrimation, urination, diarrhea, gastrointestinal cramping, and emesis. The pinpoint pupils, or meiosis, are a classic clue. Notice the central red box emphasizing the killer bees: bronchorrhea, bronchospasm, and bradycardia. Bronchorrhea and bronchospasm are clinically the most dangerous muscarinic findings and major causes of death. The right side of the slide lists the nicotinic effects: muscle weakness, fasciculations, twitching, and eventually paralysis. Remember that paralysis includes respiratory muscles. And finally, the CNS effects. Patients may become confused, seize, develop a coma, or stop breathing centrally. So if you ever see a patient with pinpoint pupils, secretions everywhere, wheezing, muscle twitching, and altered mental status, think cholinergic toxicity immediately. This slide emphasizes urgency. Look at the large warning sign saying, "Do not wait." In real-world toxicology, treatment is primarily clinical. You should not delay therapy while waiting for cholinesterase levels. If the patient looks cholinergic, treat the patient. Now look at the right side of the slide. You can see the role of cholinesterase levels. They can support the diagnosis, but they should never delay management. Then, at the bottom, we have the POP scale, the Peradenia Organophosphorus Poisoning Scale. This is used to estimate severity. Clinical findings like pupil size, respiratory rate, fasciculations, heart rate, and level of consciousness help categorize poisoning into mild, moderate, or severe. But remember, bedside clinical judgment is still the most important tool. In emergency medicine, the patient in front of you matters more than the laboratory value that hasn't returned yet. This slide highlights the first and most important management priority: airway and breathing. When these patients arrive, your initial approach should be systematic. Airway, breathing, circulation. Look at the left side. The patient may have copious secretions, vomiting, bronchospasm, hypoxia, or seizures. Many patients require aggressive suctioning. Now shift to the right side. You need IV access immediately. Continuous monitoring is essential. And now pay attention to the red warning box at the bottom. Avoid succinylcholine. This is a very high yield point. Succinylcholine is metabolized by plasma cholinesterase. In organophosphate poisoning, cholinesterase activity is already impaired, so succinylcholine paralysis may become dangerously prolonged. Instead, non-depolarizing paralytics like rocuronium are preferred. This is exactly the kind of detail that appears in board exams and real ICU practice. Now, let's talk about decontamination. Historically, GI decontamination received significant emphasis, but modern protocols prioritize dermal decontamination first. Look at the green box on the left. Healthcare workers must protect themselves. Gloves, gowns, masks, and eye protection are critical. These chemicals can poison providers as well. Contaminated clothing should be removed immediately. The patient should undergo copious washing with soap and water. Now compare that to the red GI decontamination box. Routine gastric lavage is no longer recommended. Activated charcoal may still be considered in selected cases if the airway is protected and presentation is early. But aggressive GI interventions are no longer automatic. Modern toxicology increasingly emphasizes provider safety and evidence-based intervention. This is one of the most clinically important slides. Atropine is the life-saving antidote. And notice the escalating dosing pattern shown visually on the screen. The dose went on doubling. The idea is to rapidly escalate the dose until secretions dry and oxygenation improves. Keep in mind, the goal is not normalization of heart rate. The endpoint is adequate airway control. Now look at the clinical endpoints listed on the right. Clear lungs, drying of secretions, improved oxygenation. That is successful atropinization. In severe poisoning, patients may require enormous doses, sometimes hundreds of milligrams over time. That surprises many learners initially. But remember, atropine is titrated to physiology. You are treating muscarinic excess, and inadequate atropine kills far more patients than excessive atropine in this setting. In patients with moderate or severe toxicity, once the desired response has been achieved using atropine bolus therapy, treatment should transition to a continuous intravenous infusion. The infusion is typically started at 10 to 20% of the total cumulative atropine bolus dose per hour. The infusion rate must then be carefully adjusted according to the patient's clinical response. The goal is to maintain adequate atropinization. Key indicators include clear lung auscultation, a heart rate greater than 80 beats per minute, systolic blood pressure above 80 millimeters of mercury, dry axillae, and pupils that are no longer pinpoint. At the same time, clinicians must avoid signs of atropine toxicity. Warning signs include confusion, pyrexia, absent bowel sounds, and urinary retention. Continuous monitoring is essential. The infusion should be titrated based on the patient's response and gradually tapered as recovery occurs. If atropine toxicity develops, the infusion should be temporarily stopped until symptoms resolve. Once the patient stabilizes, the infusion may be restarted at approximately 70 to 80% of the previous infusion rate. Careful titration and frequent reassessment are critical to balancing therapeutic benefit while minimizing toxicity. Now let's discuss pralidoxime, commonly called 2PAM. Unlike atropine, which blocks muscarinic receptors, pralidoxime works at the enzyme level. It attempts to reactivate acetylcholinesterase, but timing is critical. Look at the warning on the right side of the slide. Oximes must be given before aging occurs. Once aging stabilizes the enzyme bond, reactivation becomes impossible. That's why early administration matters. Now look at the dosing section below. There's typically a loading dose followed by continuous infusion. Oximes are especially helpful for nicotinic symptoms. muscle weakness, and paralysis. Remember this contrast. Atropine dries secretions and improves bronchospasm. Pralidoxim helps restore neuromuscular function. Together, they form the backbone of antidotal therapy. Magnesium sulfate has gained increasing interest as an adjunctive therapy in organophosphate poisoning. Look at the statistics presented. Some studies suggest reductions in mortality and intubation rates. Mechanistically, magnesium may reduce acetylcholine release and stabilize membranes. It may also help with arrhythmias and seizures. Now, this is important. Magnesium sulfate is not the primary antidote. Atropine and oximes remain the core treatment. But adjuncts like magnesium represent evolving practices in toxicology. As evidence grows, supportive therapies continue to improve outcomes. This is a good reminder that medicine constantly evolves. Protocols are not static. This slide beautifully integrates the pharmacology. Notice how each medication targets a different component of toxicity. Atropine blocks muscarinic receptors. Pralidoxime reactivates acetylcholinesterase. Diazepam controls seizures and may reduce central nervous system injury, and magnesium acts as an adjunctive stabilizer. This is a systems approach. Instead of thinking about a single antidote, think about multiple simultaneous physiologic targets. That's exactly how modern critical care works. A complex disease requires layered intervention. Now we move into one of the delayed complications, intermediate syndrome. This usually develops 1 to 4 days after exposure and is a favorite exam topic. It is due to the downregulation of postsynaptic nicotinic receptors following prolonged depolarization. Notice the muscle groups highlighted on the slide. Patients present with weakness of neck flexors, proximal muscles, and respiratory muscles. The initial improvement seen after atropinization later deteriorates. Importantly, this syndrome is not caused by ongoing muscarinic excess, so simply giving more atropine may not fix the problem. That delayed respiratory failure is the hallmark. These patients often require prolonged ventilation and ICU care. Clinically, always monitor organophosphate patients even after apparent stabilization. Delayed deterioration is real. Now let's discuss the late neurologic complication, organophosphate-induced delayed polyneuropathy, OPIDN. This typically develops weeks later. Look at the timeline on the slide. This occurs through a different mechanism involving neuropathy target esterase. Patients develop stocking glove sensory loss and symmetric motor weakness. The important teaching point here is that organophosphate poisoning is not just an acute event. It can produce long-term neurologic disability. That's why follow-up and rehabilitation matter. This slide summarizes the entire disease progression. First comes the acute cholinergic crisis. That's the emergency phase with secretions, bronchospasms, seizures, and respiratory failure. Next comes intermediate syndrome, delayed muscle weakness and respiratory compromise. And finally, delayed polyneuropathy. This timeline framework is incredibly useful clinically. When you understand which phase the patient is in, management becomes more intuitive. Emergency stabilization, ICU monitoring, long-term rehabilitation. Different phases require different priorities. This final slide brings everything together into a practical emergency algorithm. Step 1, airway and oxygenation. Step 2, safety and decontamination. Step 3, aggressive muscarinic reversal with atropine. Step 4, enzyme reactivation with pralidoxime before aging occurs. Step 5, adjuncts and ICU monitoring. And finally, watch carefully for delayed complications like intermediate syndrome. As we close, remember this key principle. Patients with organophosphate poisoning usually die from respiratory failure. If you control the airway, dry the secretions, reverse bronchospasm, and support ventilation, you dramatically improve survival. Toxicology can initially feel overwhelming because of the pharmacology, but if you organize it into mechanisms, toxidrome, airway management, antidotes, and complications, it becomes much more manageable. If this walkthrough helped you, consider reviewing the slides again and actively talking through the clinical sequence yourself. That's how toxicology becomes intuitive. Thank you for watching.
This content is not intended for clinical guidance, use in medical clinics, or patient management. It serves as supplementary information for medical students preparing for examinations and should be used in conjunction with their official course materials. In the event of any discrepancies between this content and the prescribed curriculum, the curriculum shall take precedence until further review and clarification are made by the concerned students. The contributors to this video have exercised due diligence, but the content may become outdated quickly.